Okay. Hi there, I'm Faith. I'm one of the cardiac techs, and we are, part of the cardiology outpatient and inpatient teams. We take care of the resting ECGs, Holter monitoring, hookup and analysis, as well as stress testing, assisting in the electrophysiology lab with ablations, pacemaker clinic, and event recorders like remote telemetry. So the topic that Cecilia would like us to talk about today is Holter monitoring. And we have a lot of patient families that call it a holster, which is why I have this cowboy here. But it's Holter, and it's named after, I guess, the inventor. So our Holters, we're actually playing with a new type of monitor, but our standard procedure is a 24 to 48 hour recording, which is this little white box. We use the GE brand. Unfortunately, when you're tied into the software system, you can only buy the hardware that goes along with it, and these are about $3,000 each. They're not waterproof, so the patient is only able to take a shower before or after the procedure. And we do this for our cardiac outpatients as well as inpatients. They may not be cardiac patients with structural heart disease, but they could have symptoms that they want to rule out of cardiac origin. Our Holter has 5 stickers which produce 2 lead channels, and this is the preview. So we always want to ensure that the R wave is the strongest waveform and very clear, as well as the P and the T respectively clear but not enlarged, where the R wave would be disregarded in the analysis. Otherwise, it makes the algorithm a bit difficult to work with. We do encourage our patients to be active with it on unless they have physical activity restrictions. Usually the cardiologist would like their heart rate, to have some sort of physical activity or increase due to physical activity, whereas we don't want them just sitting on the couch all day. It kind of doesn't provide the diagnostic value that they'd like to see. We do tape our electrodes over with Hypafix tape. If you don't, you will get a lot of shaking of the cords, which you probably see on telemetry when patients are in-house. However, we want to get the clearest signal, and we don't like gaps, especially with pacemaker follow-ups. If there are gaps, we can't really tell if there's oversensing or undersensing issues, if there's artifact that's in the way of us seeing a clear heart rhythm. And the reason why I put this remove box, these are adhesive removers. I was just saying we use the tape and we package up the wires and tape it to their midsection as well. A lot of our patients hate Holter monitors. They would rather, I've heard from heart transplant patients that they would rather do an angiogram than do a Holter monitor. So to kind of help them out, we always give them this brand. This brand is the best brand for adhesive removal. They can soak the tape on top and disconnect the cords, and they actually mail it back to us if they don't live in the city. We have a lot of patients across the province, that, if they're beyond usually 30 kilometers, we ask them to mail it back through tracked parcel. And in-house, we will scan it the next day. And those are our priority scans. So a lot of the time, patients get this for ruling out arrhythmias, as well as assessing maybe the drug effect on their minimum heart rate or maximum heart rate, especially if they're on a beta blocker. A lot of times they will do a stress test as well, but just to kind of see how their heart rate responds at night, we will definitely put a Holter monitor on. And these are just sick kid specific considerations for nursing support. I don't know if there's any new 4D nurses here. We usually call ahead. And I mean, this could apply to any hospital. If they need to take a bath, especially if they're a post-op patient, if there's any creams or Vaseline or oils, we wouldn't want that on, and that the patient and the parent is prepared. On small children, on babies, it does look a little overwhelming with all the tape, and the parents' anxiety is already quite high. So we also want to make sure that any ultrasounds, echocardiograms, or MRIs are done before we put the Holter on. I mean, if it's a kidney ultrasound, usually they can work around it, or we can leave some space. But on infants, it's a bit tricky. And then there is a patient diary that goes home with them. For outpatients and inpatients, we always ask that they record their activity every I put 2 to 3 hours here, but 1 to 2 hours is better. Even if they are just asymptomatic and sedentary, just sitting around or doing their homework. That way, if there's any arrhythmias or tachycardia or anything a little bit abnormal looking, we can track their physical activity level at that time. Medications, of course, even non-cardiac medications, we ask them to enter. Things like domperidone and other prolonging QT medicines may not necessarily be cardiac, but they may have cardiac side effects. So we do want them to enter that in. And whether they have any abnormal vital signs, if they're small or young, usually the parents will say, oh, I take their heart rate at home and it says that they're at 180 beats per minute with this Apple Watch. So we do ask them to make some sample entries, as well as, of course, symptoms. And there is an event recorder button, just a timestamp. But a lot of times that gets pushed accidentally, or the kids, the 3-year-olds, get into it and play with it. So documentation is very important. And in-house, we do ask the RN to at least review the diary before it's submitted to make sure all the medication administrations are complete, and if there's any abnormal, questionable vital signs that they'd like to add. For pacemaker and internal cardiac defibrillator patients, we do routinely Holter monitor these patients just to ensure that if any new settings, like to do with the sensitivity or the refractory period, or even just their low rate or upper rate, or any other mode switches that are made to the pacemaker, we want to make sure it's optimized. So to do this, we do need a Holter monitor. And we do note always the new setting changes on the report. At sick kids, we do ask for them to be returned by 12 p.m. the next business day so that we can, if it's a 24-hour or the day after, if it's a 48-hour Holter, to ensure that we can scan the recording and provide the physicians the report. And we just removed telemetry monitoring on all the units. It's incompatible, and it only provided one channel, so a lot of times there was a lot of artifact. So now we don't do any more telemetry monitoring. So like I said earlier, usually we would like to qualify any questionable rhythms to see if it's actually true ectopy. Things like atrial ectopic tachycardia can be very tricky to see on telemetry, mainly because it is typically narrow complex and it has a gradual warm up versus with SVT, it's a very abrupt tachycardia, whereas AET can be thought to be sinus tach if you don't note it on the telemetry right away. It's very tricky. So this is why we have Holter monitoring a lot at sick kids, and also to quantify. So if you were to upload the monitor, a lot of people think that we just upload the monitor in the computer and the computer does all the work. Every monitor you upload will say that every patient is in VT for extended periods of time, or SVT. It will label everything or half the recording abnormal. So the job of the technologist is to go through the data and to ensure that we quantify it completely accurately as much as possible. And generally we do. Nine times out of 10 we will. There are some Holters that may overcall or be undercalled, but we can generally show the strips and the examples. And of course, this is used for diagnosis management to ensure there's medication compliance, especially with our teenagers who may just take, half of their beta blocker, or they may skip days, and to ensure that they're not being physically active to a certain exertion level. So, we can see, even if they don't write it in the diary, we can see if their heart rate reaches a certain point. And of course, medication, if it affects the burden of their ectopy, if it's effective. So here, this is just the cover sheet of the report. You can see that we have, the general, how many QRS complexes in total. We quantify paced beats, of course, ventricular and supraventricular, and so on. Bundle branch, we usually don't. We just qualify it, so we show examples. And junctional and aberrant beats we do as well, of course, as AFib and aflutter and noise. And here we have the heart rate. So the minimum, we will show a strip, average, the maximum, and then how many beats in tachycardia. So we have parameters according to age group. So of course, an infant's tachycardia range would probably be higher at 180, whereas a bradycardia would be at 60. This patient was probably, so 15 is the upper threshold for this range. This is usually from 8 to 15, 8 to 14. And then the maximum R to R interval is very useful for seeing how long pauses are. So in this case, this patient's pause was 1.59 seconds. And the Z score here corresponding, it's not significant. So if they had a 2-second or 3-second pause, that would actually be quite long. And we do look at all the pauses, but that would be suspicious for AV blocks. And then we have the supraventricular count here, and then bigeminal cycles, if there are any couplets, and runs, of course. And then ventricular, so how many isolated beats, couplets, bigeminy, any runs, what is the longest run, and what is the fastest run. So in this case, I just took her example. Even though you have the runs here ventricularly listed, of course, the staff would like to know, is it a biphasic ventricular tachycardia? Like, is it monomorphic? Is it polymorphic VT? We will show examples of the different types of VT if this patient has different kinds, the polymorphic versus the monomorphic. So this patient does have polymorphic VT, which would change their diagnosis management. And sorry, I wanted to show as well, this patient did write down that they were just walking around. This patient had catecholamine polymorphic ventricular tachycardia. So anytime this patient was either psychologically stressed or did some physical exertion, those stress hormones would induce polymorphic VT. And a lot of them are on different types of medications. This patient was still query CPVT, but this Holter helped decide whether they truly have it or not. And it said monomorphic VT, but that's not the case here. So this is just an example of this patient's diary. So, just benign sort of activities, just walking to the mall. If they became upset, did homework, and so on. The bedtime and wake time is also important. A lot of kids during this pandemic have altered their sleep cycles, so they're sleeping at all times of the day. Now that they're gone back to school, kind of gone back to regular bedtime, wake times, but teenagers, it depends. And this is an example of a report here for that patient. And, they will just type out the important facts that need to be noted. And they didn't know if, they wanted to mention that the ventricular ectopy clustered during certain times. So whether they were compliant with their medication, maybe they missed a dose. We also produced some trends. So the heart rate histogram here on the heart rate histogram, there's episodes and the heart rate. So 45 is the lowest heart rate, and a lot of heart rate is sitting at around the 50 to 60 beats per minute heart rate, and up to 170, we'll say. And R to R interval, so the shortest intervals to the longest, and the heart rate trend, so beats per minute with time of day. We would select periodic strips kind of based on what we see at these higher heart rates. We'll always take extra care at looking, and R to R interval trend based on time of day as well. This is just an example of how the monitor or the pacemaker Holters can show very subtle changes or very subtle evidence of oversensing or undersensing. So in this case, we have a dual chamber pacemaker. We have a pacing spike for the A, for the P wave, and then a pacing spike for the V. And it's going at a very regular rate. And then all of a sudden we have a prolonged pause and then continues on. So here we would, this is not a very long pause, but according to the settings, it was too long of a gap in the heart rate. So the heart rate decreased to a point. So let's just say it was supposed to be no shorter than 60 beats per minute, and this was, say, 50 beats per minute. We would start to be suspicious of oversensing. And in this case, it did oversense the T wave. that was the issue, and it did not pace accordingly. And in this case, we have a very obvious pause that's quite prolonged, and we have P waves. So this is a ventricular pacemaker, so it's probably VVI. And we've got paced beats here, and then we have all of a sudden loss of capture and no pacing. Pacing has been inhibited for some reason. So these are things that we always take a good look at to see if it's oversensing, undersensing, loss of capture. If it's loss of capture, we're talking about possible lead fractures or dislodgement. So yep, that's about the pacemaker function. And here's another pacing malfunction here. We have a normal beat and then a ventricular paced beat and then a normal beat again, but then we have a ventricular spike on the T wave. And this is, for some reason, it's undersensing. It didn't see the T wave, didn't see that we're in a refractory period, and then a small pause and back to normal. The normal beats came through, the junctional beats. So this also, it could be mistaken for artifact if it's just on telemetry or even on Holter, but we would look for more examples of this. Oh, and that's the end of that slideshow. Is there any questions about the Holter monitoring? Sorry, I don't even know where to look. Oh, that way, great. Great. Guess I can close this and I'll just go to, that's okay. I figured you were here. Okay, so I'm just gonna move on to the ECG practice.